So thank you very much. It's a great pleasure to be here today. And I'm going to talk to you about prevention of diabetes. I will concentrate on type 2 diabetes since in type 1, first because of the shortage of time, I don't have too much time. And second, because altogether, if you look at type 1 diabetes, 40 years of a very intensive research is altogether disappointing. So if we look at primary prevention, we do have data to support that, for example, breastfeeding or such a thing might prevent type 1 diabetes in certain percent of the cases. But if we look at secondary prevention, when you already have biomarkers, but you don't have the clinical disease, actually we don't have any data to support that we can prevent the progression from secondary to tertiary to the clinical. The only big study was with insulin, and insulin given at the very early stage when there were several antibodies, islet antibodies, but altogether a very large study that showed that the hazard ratio, if you look at insulin versus placebo, was 1. And although there was a subgroup of those who were treated with oral insulin, suggesting that oral insulin might prevent the progression to type 1 diabetes, to the clinical, altogether we don't have data to support it up till now. If we look at tertiary, many studies have been done with different immunomodulators, with injecting intra-islets proteins, either GAD, or insulin, as I mentioned, or diapep 277, or many different. And altogether, although phase 2 study looked very promising when you use immunomodulator, when it came to the phase 3 studies, it all failed. And the feeling is that just single immunomodulators or single anti-inflammatory won't stop the progression of the disease. You might need to have several immunomodulators together. This is too complicated to do, so most probably we are not going to see breakthrough in the prevention of type 1 diabetes in the near future. Okay. There was somebody here running with this thing, but I'll do it from here. Okay, so looking at type 2 diabetes, you're well aware that type 2 diabetes is an epidemic, that if in 1980 there were around 100 million diabetic patients in the world, today we talk about 450 million, assuming that within the next 15, 20 years, it will grow to above 600 million people. And if we look at pre-diabetes, actually it's the same thing. Pre-diabetes assumed to involve around 400 million people worldwide. And I'm not sure that these numbers are correct, because just looking at China, in China, they published about 10 years ago that they have 90 million diabetic and 150 million pre-diabetic. But on data that I was involved in the last 1 or 2 years in Shanghai and its surrounding, they have demonstrated that after the age of 20, 12% of the patients have diabetes and 50% of the patients have prediabetes. It sounds crazy, but this is the data that we have. So maybe the numbers are even much beyond what we can see. Okay, now it's clear that prediabetes and diabetes is strongly related to two things, to your age and to your weight. So if your BMI is high and if you're old, your chances to be pre-diabetic is very, very high. And similarly, your chances to be diabetic is very, very high. And a patient at 45 years old who had pre-diabetes, mainly those who are obese, are at a very high risk, more than 50%, to develop diabetes in their lifespan. Now, what do we know about prevention of diabetes? This is all old studies. Many of you all know them. Studies that looked at lifestyle, at different drugs, and what was shown that lifestyle, that seems to be the most important way to prevent diabetes, is really have high effectivity, mainly if we look at the DPP, a study on 3,000 patients in the United States, or the FIN-DPS, the Finnish study on more than 500 patients in Finland, both demonstrating that lifestyle is have high efficacy in preventing diabetes. Also different drugs, metformin, as mentioned, not as effective as lifestyle, however effective, and other drugs that prevent absorption of glucose, like acarbose, drugs that prevent absorption of fat, like Orlistat, or drugs that improve blood glucose control, reducing glucotoxicity, lipotoxicity, and maybe through this mechanism prevent diabetes. And we won't go to mechanism because of the shortage of time. We can discuss it later on. The most effective drug seems to be the PPAR gamma. PPAR gamma actually reversed the main pathology of diabetes, which is excess deposition of fat in the wrong places, in the liver, in the muscle, causing insulin resistance, in the pancreas, causing beta cell death and beta cell failure. So this seems to be the most effective drug to prevent diabetes. Now, if we go back to the DPP, we can see that actually, if you look at the difference between metformin and lifestyle, in patients at a very high risk to develop diabetes, these are the patients who has fast plasma glucose near those of diabetics, or hemoglobin A1C near those of diabetics. In those patients, the effect of metformin is quite close to the effect of lifestyle. And actually, we also know about subgroups. So altogether, lifestyle is the best, but we can see that there are certain subgroups of patients who will benefit from metformin nearly as much as they benefit from exercise. These are younger patients. These are patients with BMI above 35. These are patients whose fast plasma glucose, when they start the intervention, are above 110. And these are patients who had a story of gestational diabetes. So, and you can see that actually the benefit is very similar versus placebo. So there is a 50% reduction in the risk to develop diabetes when you either use intensive lifestyle or metformin. Similarly, when your BMI is above 35, and similarly, if you have a history of gestational diabetes. However, there is a big difference in one thing, and this is how many patients will normalize their blood glucose level. Not how many will progress to diabetes, but how many will normalize their blood glucose level upon treatment with either lifestyle or metformin. And what you can see, that lifestyle actually has a very strong effect on normalizing blood glucose level, while metformin, although it has an effect, the effect is marginal, and it's surely not as strong as those of lifestyle. And this is very important because the DPP was a short-term study of less than 3 years. However, the follow-up was extended to another 12 years, so altogether 15 years. And this enabled them to see what happened to those who were originally treated with lifestyle or with metformin. And what you can see, that those people who had at least once reduction to normal glucose level had a much better prognosis over time. And just to remind you, those that were under lifestyle, many, many more have actually converted to normal glucose level than those who were on metformin. So there is a great importance for lifestyle, even in those cases where metformin and lifestyle were shown to have a similar effect on the patient. Now, based on this, there is now, in 2016, the DPP in the US became national. Now, it's not only based on this. There were several studies in the United States. The VA study, or not a study, the VA actually looking at what happened in real life, exposing more than 500,000 people to to the DPP plan and demonstrating an effect. The problem with the VA was that only 13% of those who were invited to take place actually did, at least being in one meeting out of the 12 that was suggested. It was also tried in a big program with YIMCA in 40,000 people, and also tried on Indian people who are known to have a very high risk to develop type 2 diabetes, and demonstrated that in those group of people, intervention was very successful. So what is the problem? Let's have an intervention and solve the problem. One more thing before we go into it, I also want to show you shortly, to go over with you shortly about the Finnish study. The Finnish study actually tried to change five variables. To have a weight reduction of more than 5%, to reduce fat intake to less than 30%, to reduce saturated fat intake to less than 10%, to increase fiber intake to more than 15 grams per 1,000 calories, and to increase the exercise. And you can see that in the intervention group, much higher percentage achieved this 5 than in the control group. Now, also in the FIN-DPS, they did, also in the Finland program, they continue to follow the patient, demonstrating that intervention trying to reduce all these 5 variables give a much better prognosis to the patient when it comes to free time from diabetes. Now, what was interesting was to see that the main effect, or the most important effect, was the effect on weight. So patients who lost more than 5% of the weight, which was the aim of this study, actually did much, much better than patients who had stable weight, or surely those who gained more than 2.5% of the weight. But even more interesting was the fact that those patients who were able to achieve at least 4 of the goals, or even 5 of the goals, didn't develop diabetes. And this shows that it's not only one thing. You have to involve lifestyle, but to involve lifestyle also with other important variables. Now, why is that important? First, it is important because it's important to reduce the conversion from prediabetes to diabetes, and if possible, to increase the conversion from prediabetes to normal. But in the Dakwin study, the Chinese study, they also demonstrated that after 12 years, the result of reducing the progression to diabetes translated to reduction in mortality, which was very, very important. In this regard, the DPP study is actually a little bit disappointing, because as I told you, in the DPP study, after 3 years, they continued to follow the patient for another 12 years. Now, it's true that those patients who were on placebo, 20% of them started on the way to take metformin. And in the other side, those who were on metformin or lifestyle originally, only 70% of them stayed on metformin. However, when they look at the results, you can see that over time, the DPPO, the 12 years follow-up, they will continue in less cumulative incidence of diabetes, and also the weight loss were in a way maintained for many years and even later on. The disappointing thing is that we would expect that after 15 years of difference between the intervention group and non-intervention group that actually reduce conversion to diabetes, we will see reduction in macrovascular, or at least in microvascular disease. And this was not shown. Actually, there was a similar percentage of retinopathy, nephropathy, neuropathy, and macrovascular disease in all the 3 groups. How can this be explained? You can read the discussion in the paper. It's hard to understand. One thing is, it might be that we need a longer follow-up in order to show the effect in those patients. Now, one of the big problems is that, the DPP on 3,000 people costs huge amount of money. So how can you translate the DPP to millions of people without asking for a huge amount of money? And as I told you, it has been done together sometimes with the payer in IMCA, in the VA, and in American Indians. However, we in Israel came with a new solution that I want to shortly show you. And this solution said that we have to define the situation and look for a proven solution, and we bridge it we bridge the funding harder with a new mechanism. And I want to show you the mechanism, and within years we'll know if it works or not. What we have done is what we call social impact bond, a pay-for-success mechanism. So what stands behind it? The government understands that they have to do something in prevention. The only problem is that they don't have money, they don't have time, and they don't understand how important it is. So then they look for somebody else that will do it for them, the intermediary. And this somebody should need to have two things. One, be able to raise money. And the other one, with that money, to hire a non-profit service provider that will conduct the intervention, and also somebody who will evaluate whether this intervention has succeeded. And if it is succeeded, those that benefit from it, meaning the health organization, the social security, the country will pay again with dividend to the investor. So what we did in Israel, and we're already doing it now, is that 20 million shekel were given from different philanthropic or different people who invested in this social impact bond. Now, we were sitting with the health medical organization, and we decided how much do we save them for each patient who will not develop diabetes. And then we said, okay, using the DPP, we're going to reduce the conversion to diabetes within the next 5 years by 40%. And we took a very high-risk patient, as you saw in the DPP. And now, in case we will be able to show that we reduce 40% of conversion to diabetes, will be repaid by the following: by the HMO themselves, and by the Social Security, and by the Minister of Finance. So this is a written contract that, if it will work, actually will pay back, and then you can use it in the circle. Now, another big problem of prevention of diabetes that I don't think has been solved is the fact that even when you suggest to people to do prevention and you give them everything they need for free, they just don't come. For example, in our country 10 years ago, one of the large HMO decided to see what is better. Is it better to have a group therapy, or is it better to have one-to-one therapy with the medical staff? So they talked to the doctor, and they invited 3,500 patients with prediabetes. 93% of them came to the clinic and talked to the doctors. And the doctors tried to persuade them to come to a 10 meeting, either face-to-face or as a group. Who wants to guess how many patients came to that initiative? How many? 20%. More, less? 7%. Okay, and this is with all the effort and after they already came to the doctor. Now, if you look at the United States, and this is what they call lack of awareness of prediabetes among United States. So you can say they don't understand what it is, But even when they understand what it is, and even when you explain what it is, 93% of the population in the United States also do not understand or are not willing to put a lot of effort to prevent their progression from prediabetes to diabetes. Now, so this raised the issue of the drug, of metformin. But if you remember, I demonstrated to you, the drug alone is not enough. You need to find a way to change lifestyle. And shortage of time, I do not present to you, but digital therapy can overcome the gap. For example, large study that had been done in India, when they just SMS the patient every second week, reduced diabetes, development of diabetes by 50%. So maybe it's hard for people to come 10 times or 12 times or 20 times to the clinic. But maybe if you bring him just for the first time and after 1 year, the second time, or after half a year, but you will close the gap by different electronic support that will watch their steps, that will watch what they eat, that will give them suggestions, that will SMS them, maybe this could close the gap. However, we do have hypotheses, and I'm not going again to mechanism, that part of the conversion from prediabetes to diabetes is related to glucose and lipotoxicity. So if we can reduce blood glucose level and blood lipid to near normal, not to mention if you can do it by reducing the weight of the patient, the chance to normalize blood glucose level and to increase the time that you'll be free of diabetes very much as was shown in the DPP. And actually we have today 4 drugs that do not cause weight gain or actually cause weight loss and that could seem to be able to prevent diabetes. The bariatric surgery has very high potential, as you're well aware. GLP-1, recently there was a scale study with the liraglutide demonstrating that you can reduce by nearly 80% the risk to develop diabetes using GLP-1. SGLT2 inhibitors, we don't have yet a good randomized study to show that it prevents diabetes, and similarly not with DPP-4. So, because this is such a big issue, Dr. William Cephalou, who used to be the editor of Diabetes Care, used to have what we called Diabetes Expert Forum, and one of those Diabetes Expert Forum was devoted to the issue of prevention of diabetes. This is a very, very good paper, actually led by William Cephalou, where you can see all the data that we have all today, including what we suggest for the future. One of the things that was raised is that in the United States, metformin is not approved for the treatment of prediabetes. And maybe the FDA should change the way they work up till now and approve this drug for prevention of diabetes, because we do have enough data to support it, in spite of what we learned today, that it can increase the risk of dementia. So this is the situation in the United States today. Each year, around 1.5 million to 1,700,000 people developing diabetes. It's stabilized over the last several years, but we need to find a way to start and decrease this number by intervening surely in general, changing the lifestyle of the population. And you know what is the percentage of obese people in your country now? 40% are obese. Only 40%. Only 40% in the United States have BMI above 30. So actually you have to try and deal with the whole population, what we're doing in my country now. But no question that we have to be much more active in prediabetes, mainly in those patients at a very high risk to develop diabetes within several years, involving both lifestyle and medicine. Thank you.
Any burning questions? Because we'll have a panel here.
Yeah, just one point. So, as you said, only 3% of the pre-diabetic in the US are on metformin. So the DPP investigators went to the FDA and said, we'd like you to approve the drug, because if you don't approve the drug for prediabetes, the healthcare providers are not going to pay. So the FDA had two responses that were amazing. First of all, they said, even if you would come with diabetes, diabetes is a chemical diagnosis, and only 40% of the people 10 years later will develop some complications. So we wouldn't approve it even for diabetes, but for prediabetes, of course, we wouldn't approve it. And the second thing they said, if you want to pre-approve it for prediabetes, then change the definition of diabetes. Don't come to us. You can decide that diabetes is 5.8 hemoglobin A1C and you can get it. But it shows you, really demonstrates one of the problems with dealing with the FDA, who has totally different notion of what to treat.
Yeah, but you know that for shortage of time I didn't say it, but in the DPP itself, if you remember, I said that when you followed them 15 years, there was no difference in the complication between metformin, but those who develop diabetes have 28% increase in complication. So even from those data, you have to prevent diabetes as much as possible. And the other thing is that in the United States today, those patients who can benefit a lot from metformin, meaning those with BMI more than 35, women who had gestational diabetes, and young people, only 1%, 1.5% are under metformin. At least in my country, I can tell you 15%. So we are doing better, but also far away from what's needed.